Greetings, everyone. Good morning and good evening, wherever you are. Today we have Dr. Radhika Jain, who is joining us from Stanford University. Radhika is a postdoctoral research fellow at Stanford University, does work on health, global health, a bunch of projects on India. And she finished her I think, PhD from Harvard. And right now, today, she is going to present a paper on how private hospital behavior changes with government health insurance in the Indian context, joined with Pascaline Dupa. Thank you, Radhika, for making time for this seminar series.
Thanks so much for inviting me. Okay, let me start. Sorry, I have to share my screen first, right?
We can see your screen. Go ahead.
Yeah. So thanks, everyone. This project is about looking at private hospital behavior under government health insurance in India. And it's joint work with Pascaline Dupa, and let me take it away. So it's not new to this audience that sort of lower and middle income countries have been expanding public health insurance to meet the goals of universal health coverage, which are providing access to high quality care alongside financial protection. And these programs have been scaled up in India since about 2008, quite rapidly, and now they're sort of across various states and as well at the central level. And these programs have sort of several similar characteristics. They all tend to target poorest households. They focus on secondary and tertiary hospital care. They include the private sector deliveries done through the private sector as well as the public sector. And the idea of this is to increase access, choice, and quality. Patients under these programs are entitled to free care, and this is part of the sort of financial aspect goal. And additionally, these programs sort of operate on a bundled, sort of respectively set hospital reimbursement system. And this is sort of different from fee-for-service, where you pay for every procedure or diagnostic provided. Instead, you sort of set a fixed rate based on a diagnosis or a visit, and it's sort of a flat, prospectively set rate. And the idea of this is to contain program costs. The evidence to date is somewhat limited on these programs. It's sort of mixed, and I won't cite all the papers, but broadly we find there seems to be some increase in healthcare utilization under these programs, but very modest or no effects on patient health expenditures, despite several years of expansion and substantial public spending on these programs. So I'm going to focus on two aspects of these programs. One is enlisting the private sector for delivery. I think, again, this audience is very familiar with the problems in both the quality of the public sector and the difficulty in reforming it. And so sort of delivery through private agents is sort of out from this. And the idea is that it can leverage market mechanisms to improve quality and respond to patient demand. But, there's a large service delivery literature that talks about the unique challenges of both monitoring and appropriately incentivizing private agents. And really, this is a huge, under the guise of insurance, service delivery through healthcare delivery through the private sector is a really big policy change in India, but there's very little evidence on how these private hospitals are actually behaving with these programs. The other part of the design that I mentioned was these bundled payment systems. Like I said, this is sort of a bundled payment is sort of a flat payment rate that's set by the government in a sort of ex ante for an entire visit, or it's very sort of similar to Medicare in the US. And it's a form of risk sharing with hospitals, right? That no matter how expensive a patient is, maybe they need a lot more things, but the hospital gets paid the same amount. And the idea is that it can both increase the efficiency and therefore, sort of increase the hospital's incentives to be really efficient within this rate, and so therefore reduce the costs of the program, alongside financial protection for patients when they're entitled to free care. But very importantly, the effectiveness of bundled payment systems really requires ensuring that these reimbursement rates that you have set are based on cost and adequately cover the costs of the sort of range of patients a hospital expects to see. And they require effective oversight. If the idea in these programs is that you pay a hospital a fixed rate and then they should provide care for free, you need oversight to ensure that they are actually providing care for free. And in India, there's very little data on hospital costs. So these rates are sort of set somewhat arbitrarily by panels of doctors and experts. And there's very, very weak hospital monitoring. So this sort of innovative payment system that's been used in places like Medicare is now sort of in an Indian context is very different. And again, there's a huge literature. I can't even begin to sort of start citing them on how private hospitals behave in high-income countries, in the US in particular, and how do they respond to reimbursement rates. But there's very, very little evidence from the Indian context, which is unique in that it has largely unregulated healthcare markets and institutional capacity both to monitor hospitals and to design the sort of data that you would require to set reimbursement rates and things. These things are sort of missing in this context. And so you would expect that these program design elements may not function in the same way in the Indian context, but there's very little evidence on this. So
Radhika,
this
can I ask a
paper,
quick question? Sorry,
sure.
I didn't want this, Chirantan. So you said that the rates are arrived at in somewhat ad hoc manner, but my understanding of working with the Karnataka program is that they are benchmarking with other peer programs in Andhra Pradesh and other programs. So I don't know what I think your data set is from the Rajasthan government context, but they would have probably done some sort of a benchmarking. And the second point is, you said it's unregulated healthcare markets in India. Is that true? I mean, it's all about regulation, right? In India, in healthcare context.
So to the first question, it's true that several of these programs benchmark their rates to other programs, but the sort of original set of programs, in none of these contexts were those rates based on hospital-specific costs. So like in the US, you would have, reimbursement rates take into account each hospital's the previous year's costs. That data just does not exist at the in any widespread manner in India. So while these programs are sort of benchmarking to each other a little bit, none of them originally sort of is based on costs.
The other thing
is that
production. Yeah. Okay.
And the other thing is, of course, that costs vary substantially across locations within India, and that's not really taken into account. I mean, it is to some extent. So typically, in Rajasthan, the way they set the reimbursement rates is it's a panel of sort of experts and medical doctors that sort of sit together and they look at rates from other contexts and then they sort of adjust it, like, based on what they think the costs are in Rajasthan, or try, so it's not a sort of systematic rate setting system at the time of the study, especially. Yeah. And on the regulation, it's just, there are regulations, but if you go into any sort of smaller town in India, you'll see sort of a full, and I'll show you some photographs of the kinds of hospitals we're talking about. There's all sorts of hospitals that aren't, officially registered, that are sort of under the government radar. I'm not talking about the Maxes and Fortises, but the sort of 3-story hospitals, right?
Okay.
Okay, so this paper, as you just said, we focus on Rajasthan and this BSBY health insurance program. And I'll get into this as just sort of a preview, but I'll get into all of these details down the line. And what we do is we exploit a policy change that sort of changes reimbursement rates for different packages by different amounts overnight. And the other cool thing about this paper that I think is cool is that we have a unique data set where we have the universe of administrative claims filed by hospitals under the program. And we use that to link that to patient surveys shortly after their visit to the hospital, which allows us to sort of get into the black box of the hospital-patient interaction. And basically we, broadly construed, we sort of take advantage of this sort of exogenous change to look at how hospitals respond to it and therefore understand something about their behavior. And the broad things we look at, one, I'll show you results on coding manipulation. So coding manipulation, or upcoding, is essentially filing a claim for a package at a higher reimbursement rate than that which you actually provide. And there is evidence of this happening in the US, but not, it hasn't been studied in the Indian context. And we'll show, I'll show you these sort of large and immediate changes in how hospitals code their claims when the reimbursement rates change. And I'll show you lots of supporting evidence that this is really about, a lot of this is about coding manipulation, not just real supply responses. The other thing is that we find evidence that hospitals both, that there's sort of both increases and decreases in upcoding, and sort of what you kind of infer from that is that hospitals are sort of engaging in upcoding strategically, where they make a sort of risk-reward trade-off and reallocate their upcoding to where they gain the most from it. The next result we show is that even after accounting for the upcoding, there are in fact real service volume responses, a sort of supply response to the increase in reimbursement rate. Paying more encourages hospitals to do more of a service. And then the last set of results is really focusing on out-of-pocket charges. Now, I mentioned earlier that these programs, including the one in Rajasthan, entitle patients to free care. What we show, we find sort of, this has been sort of anecdotally discussed, but we present the first large-scale evidence of pervasive out-of-pocket charges for care that is mandated by the program to be free. And then we kind of, take advantage of this reimbursement rate change to see how hospitals respond and learn something about what is driving the out-of-pocket charges. And I'll sort of get into the two main theories for this. But broadly, our results are, we find that increasing reimbursement rates to hospitals reduce out of the charges that they make to patients substantially by about 50%. But that means that hospitals are capturing the remaining 50% of the increased reimbursement rather than benefiting patients. And we find that this sort of hospital capture is higher in less competitive markets. And I'll discuss the implications of this. But broadly, sort of we conclude from this that out-of-pocket charges are in part compensating for the fact that hospitals reduce out-of-pocket charges when they get paid more, indicates that to some extent the out-of-pocket charges were compensating for reimbursement rates that were too low, and increasing the reimbursement rates did benefit hospitals. However, this fact that there's capture also suggests that market power or other frictions play a role in this. That's, I know that was short, brief, and quick, but we'll come back to all of these points. So a little bit about the program. So the BSBY Pamasha Swasthya Bima Yojana insurance program was launched in 2015 in Rajasthan. It basically entitles the bottom poorest half of the population to health insurance. And in this case, they learned from RSBY and reduced one of the barriers to enrollment to participation by making enrollment automatic based on your poverty status. And the program is supposed to be completely free to patients, so there's no premium or copay that the patient faces. The coverage is it's entirely free care for 1,400 services, or what's called packages in the Indian context. And so a package is basically, and as I sort of said before, this is just sort of a bundle of services based on both, some combination of diagnosis and provision. So for example, there is a package for a basic vaginal delivery. There's a different package for a vaginal delivery alongside with an episiotomy. So that's sort of based on what you provided. And there's a different package for vaginal delivery alongside preeclampsia management. So, and there's 1,400 of these packages at the time of our study. And the coverage for free care is at both public and all empaneled private hospitals. And I'll show you the numbers of those shortly. And like all the other programs, there's sort of this annual cap, which is unusual in the US, but quite common in India, to about 3,000 rupees for secondary care per household per year, and 300,000 rupees, $4,500 for tertiary care. Hospital reimbursements is, again, like I said, there's sort of a fixed rate per package, and that rate is supposed to cover all of the tests, the medicines, and the hospital costs associated with that visit or sort of service. And and the rates are sort of flat statewide. They aren't, they don't, and it was, as I mentioned earlier, it's sort of set by a panel of doctors and private hospital representatives, and they're not adjusted for either variations in local input costs within the state or for sort of patient risk. There's no risk adjustment, sort of similar to the way you would have it in the US. And in part, that's because the data required to make these things is really not available. So the monitoring and reimbursement is largely handled by the insurer, who reviews the sort of supporting documents filed by the hospitals. It's a bit, so there is substantial verification. They have a huge bank of people that are sort of reviewing the paperwork submitted by hospitals, but it is somewhat ad hoc from conversations with the insurer. They are under capacity. And there's no verification directly with the patients. And all of the claims are filed and processed through a government IT system, and that's sort of the source of data that we use. And actually, this system works really well. Then we find that reimbursements are processed fairly quickly, within a week at most, on average. And the sort of payment goes directly from the insurance into the company into the hospital's bank account. And this is very similar in design to the national PMJ program that has been rolled out, as well as state programs, other state programs. So this is what I was saying to Rantan, the sort of hospitals, the vast majority of hospitals that we're talking about in this program are relatively small. This is in Kotputli in Jaipur district, but outside Jaipur city, 3-story building, and that's a post-labor ward. So
Radhika, 1 second. Maybe this
yeah.
is a good point with that picture. So if you look at the chat window, Tarun asks that would an alternate channel for costs to enter rate setting be political lobbying by hospitals? And there's a response from Arun Tiwari saying the industry is super fragmented, so ability to lobby is ineffective. Is that true for a hospital like this?
I suspect for a hospital like this, it is true. There is, so also all of it's not, none of this is going to be documented. This is, so our knowledge is based on talking to hospitals and what they choose to tell us. But we have found that actually hospitals do coordinate. There seem to be WhatsApp groups and stuff between them. So there's some coordination and information sharing between hospitals. My sense, it's true. I'll show you. There's some like 800 private hospitals filing in a month in this program. So it is, I think, whoever said that it was fragmented, I think that is true. There are a few sort of big hospitals that probably have more say, but there's no doubt that the private hospitals do have some say in this. They were included in the discussions about rate setting, and the government has a very strong interest in making sure that the private hospitals participate. So,
Tarun, does that answer you? You may want to unmute and say something.
Yeah, so I think what you're suggesting is so it won't like invalidate your design or anything, but I think it's just important to recognize that there's at least some degree to which hospitals do try to, like, all businesses lobby for favorable consideration by the government.
Right.
And so even though the and invariably the way that they want the rates to go is higher. So even so, I don't think that this will pose any challenges to the design as I understand it. But still, I think it's important to recognize that there's at least some degree of cost-based lobbying that's happening, and that hospitals which face high costs on these procedures will have an incentive to lobby for the rate, which is for them revenue, to be higher as well.
Yeah, no, absolutely. And that's what I meant when, and the government explicitly builds in some process for that. In addition to whatever sort of behind the scenes lobbying there is, there are explicitly private hospital representatives that are involved in the rate setting, as well as the revised revision of the rate setting that we discuss here. So they're absolutely, and, to the extent that they are sort of, their lobbying is partly reflecting costs. It's true that costs are sort of making it. My point is just that, this is not done there's no sort of systematic cost accounting by all hospitals. That's the rates are not based on that. It is based on these sort of much more informal systems. But but none of that sort of fundamentally changes the implications. Okay. So yeah, so this is just some descriptive stats I wanted to show. So the red line is this is the number of hospitals participating from the very beginning of the program, sort of filing a claim in each month. And you see the public hospitals were encouraged to sort of start filing immediately, but there's a sort of fixed number of public hospitals. The private hospital participation is really increasing pretty rapidly over time, and by November 2019, there's 2/3 of all hospitals in Rajasthan are private. And this is not necessarily the case in all state programs, but Rajasthan has a very high private hospital participation. And this is the number of transactions filed each month in public and private. And again, you see sort of a very rapid increase in private hospital transactions. Sorry, and I should say the red vertical line corresponds to the change in reimbursement, the policy reform that we explored for this paper. And what you see really is that all of the increased utilization of BSBY in the recent years has come from the private sector. And lastly, this is sort of total reimbursements each month. And again, sort of you see the private sector is a huge share of total public outlays. And all of this is just to say that the private sector plays a very large role in this program and is therefore important to study. So the policy reform that we study is reimbursement. The key part of the policy reform is that it happened on December 13, 2017, and the government sort of revised hospital reimbursement rates to take effect. They really sort of took effect overnight, and I'll show you proof of that. The changes were determined by a panel of doctors from public hospitals as well as some private hospital representatives. So this thoroughly sort of to your point. And the magnitude of changes across the reimbursement change varies substantially across packages, which basically this sort of is a shock, because the costs of care don't change discontinuously on December 13, 2017. The change in the reimbursement rate is basically a shock to the profitability of different packages, which is what we exploit as a natural experiment. There were some other changes. So this was at the time that a policy is renewed, but we don't think any of them have sort of threatened the validity of what we are studying. Basically, the insurer remained the same. The premiums increased slightly, but they were paid directly by the government to the insurance, so they don't affect either the hospital or patients. The annual balance gap was the same. The claim filing and reimbursement system was exactly the same. But, even though the package rates changed, there was, however, a renewed effort by the government to empanel more hospitals, and they sort of changed their empanelment criteria to include slightly smaller hospitals, especially to increase access in rural areas. And so this makes it difficult for us to study the effect of changing reimbursement rates on hospital entry. And we really focus then on, the whole study focuses on hospitals that were already participating both before and after the reform. There were also some publicity campaigns around the time. So the data set we use is, one part of this is the insurance claims, and we have some 6 million observations to date. And the other part is patient phone surveys that we can link to the claims. So the claims data is, we were incredibly lucky. We built this partnership with the government, and they shared the insurance claims with us every 2 to 3 weeks. And the claims I'm not sure, you might be familiar with this data. It's not quite as detailed as insurance claims are here in the US, but it sort of includes the hospital information, the name, ID, whether it's public or private. And then we went through this incredibly painful exercise of using Google to basically find and geocode the locations of these hospitals. There's also information on the services provided, the packages provided or claimed, the reimbursement rate, which is fixed in any case, and the date of the service. And lastly, some information on the patient, which is the name, age, sex, phone, and phone number, as well as the household ID. And so I want to point out that with the services, there's not a lot of detail on exactly what procedures were done or what tests were conducted. That information is filed as supporting documents and provided to the insurer, but we can't observe it. So we really just see the package. So what we did for this study is we sort of selected 18 broad service types, and what we're going to call these clusters. And this terminology is somewhat important. I hope not confusing. So vaginal deliveries is a cluster. And then we identified all of the packages related to that service type of cluster. So within vaginal delivery, I gave you some examples earlier. There's a basic vaginal delivery package. There's a vaginal delivery plus episiotomy. There's a vaginal delivery plus preeclampsia management. So for these 18 service types, we identified all packages related to each cluster. And this basically covers 70% of all claims. And then for the surveys, we stratified the claims by sector and cluster, and then sampled a sort of random set of claims for survey. And we largely focused, because we had resource constraints, we largely focused on private hospitals. But there's a small pre-reform, before the reform sample of public hospital claims that we sampled as well. And basically, because we received the claims data from the government every 2 to 3 weeks, we were able to sample immediately and then conduct a survey within 3 weeks of the claim being filed. And we conducted these surveys between June 2017, about 6 months before the December reform, through July 2018, about 7 months after the reform. And the surveys, was sort of designed to fill in some of the gaps that we couldn't see from the claims data. And this is data on out-of-pocket charges, some information on the services received, care quality, program awareness, risk demographics. And, for some of the service types we include are things like stents or dialysis, or so for some things we can't get as detailed data, but for deliveries, we have 2 clusters: vaginal deliveries and C-section deliveries. And for this, there are well-validated sort of self-reported measures of what exactly happened to you and your risk and complications. So we have more detailed data for the deliveries than for the other service. So this is just sort of demonstrating the policy reform. This is actual data on reimbursement rates. And so the y-axis is reimbursement rates in Indian rupees. And this is going back to the terminology of cluster. So this is a cluster of vaginal deliveries. And these are all of the packages within the vaginal delivery cluster. And so you see one thing to note is that, reimbursement rates are flat before the reform, and then on December 13th, you see substantial changes in reimbursement rates across packages. Note also that the magnitude of these changes varies substantially. Some, like this green line here, which is vaginal delivery with forceps, does not, that rate didn't change, whereas others did. The other thing to sort of just an example to keep in mind is, if you look here on the left side, right, the blue dots are the basic vaginal delivery. That's the sort of bottom coded or sort of cheapest package in the vaginal delivery cluster. The maroon line above it is a vaginal delivery plus with an episiotomy. And episiotomy is just when you make an incision in the vagina ostensibly to make it easier to deliver a child. And what you see is that the difference between these two is about 1,500 rupees. It's a huge, huge difference. So what I'm sort of implying here is, if you did a basic vaginal delivery, if you coded it as an episiotomy, you get 1,500 rupees more. What you see after the reform is that both rates increased. The episiotomy is under the green over here. Both rates increased, but the basic vaginal rate increased substantially more. So basically, the reform changed the absolute rate of each package relative to its pre-reform period, but it also changed the distance between closely related packages. So now the post-reform, the distance between a vaginal delivery and basic vaginal delivery and episiotomy is much, much smaller. And this has implications for the coding manipulation incentives. Okay. So this is just one cluster as an example, but this happens across all of the services we study. So the empirical strategy is somewhat straightforward. It's a difference in differences using 6 months of pre-reform and 7 months of post-reform data, where we have both administrative claims and survey data. And as I mentioned, we focus on the panel of hospitals that were participating both before and after the reform, and really sort of try to look at how they, within hospital changes in behavior. So for the, I mentioned two sets of things. We want to first look at the coding manipulation. For that, the analysis is at the package rate level. Basically, we collapse the claims data to the hospital package month level, and the treatment variable is essentially the change in the reimbursement rate, which is the difference post-reform to pre-reform to post-reform. And it's a sort of standard definitive specification with hospital fixed effects, so that we're specifically looking at changes within hospital over time, as well as package and month fixed effects. And the coefficient of interest is the rate change times flow study. What I'll show you is that because we find evidence of coding manipulation, what that means is, for example, between packages A and B pre-reform, when people, after the reform, the hospitals change the way they code people across packages A and B. And what that basically means is that, trying to look at volume responses or out-of-pocket charges responses at the package level may be biased, because you're essentially comparing two different kinds of patient. Even though they have the same, the claim is for the same package, there's a different kind of person that they've been sort of due to the coding manipulation. And so what we do instead is, for the rest of the analysis, is we conduct all of it at the cluster level. And I'll show you proof that there's, this coding manipulation problem is not across clusters. And so then basically what we do, we create a cluster level treatment where it's a sort of a weighted average of the rate change across all of the packages in the cluster across the entire program. And so it's orthogonal to any behavior of any specific hospital. And for service volumes, we sort of a supply response, we use a very similar specification to the one I've already shown you, but with the cluster treatment, cluster rate change as a treatment. And then for out-of-pocket charges, we do something slightly different. We have, individual surveys, patient surveys corresponding to specific transactions, which we link to the claims data. And so then the out-of-pocket charge analysis is at the individual transaction level. So what you see is the outcome for individual I that within cluster C at hospital H at time T, with the treatment being the cluster rate change. And again, we include cluster, hospital, and time fixed effects. Okay, so starting first with the coding manipulation, and maybe, so Chirantan, I was saying, once we finish the coding manipulation, maybe that would be a good time to
sure.
take questions. So coding manipulation is basically, as I said, when the hospital files a claim for a package that has a higher reimbursement rate than the one they actually provided. Okay. And first, just a little bit of background on the monitoring under BSBY. I mean, this is a huge program. Like many programs, the principal secretary complained to me himself that they weren't given the resources to monitor this as well as they would. But basically, the hospitals are required to provide extensive supporting documentation with each claim that they file, and this is reviewed by the insurer. But of course, the universe of claims is not, so it's they sample some set of claims to review. So there is monitoring of that, and the insurer also uses looks at patterns in the claims data and flags hospitals that seem to be doing suspicious things. However, this is not, from all of our conversations, it seems like this is not systematic, nor certainly not universal. Not every claim is not reviewed. And there's no verification of services with patients. So you are sort of relying on the documentation provided by the hospital. So the point of this is to say that there are constraints. It's not like you can just code anything you want. There is monitoring of it. There is some threat of detection, but it is imperfect. And and there are some rewards to coding manipulation. So going back to what we think, coding manipulation is a function of the reward. And the reward of coding manipulation is specifically the sort of distance between a package that you provided and the package that you could upcode to, right? Like the bigger that distance, if you think about the basic and episiotomy packages, like you gain by upcoding to the episiotomy, you gain 1,500 rupees. So that's sort of the reward. The risk is kind of the threat of detection. So And the threat of detection is both a function of how different these packages are. So, to upcode a basic delivery to a VAT to one with an episiotomy is, the paperwork for faking that is sort of trivial. But, it would be very hard to sort of fake the paperwork to make a vaginal delivery look like a heart attack, right? So it's a function of how far apart the services themselves are that you're coding between, as well as the insurer, sort of how the insurer is targeting monitoring. But the thing with, there's lots of speculation that there is going to be upcoding manipulation, of course, but it's extremely difficult to really identify this in cross-sectional data. And, there's a large trove of literature even in the US that sort of shows that despite substantially more monitoring by the insurance companies here, there still is evidence of upcoding. So what we do, the change in reimbursement rates that happens sort of provides one way to sort of uncover evidence of coding manipulation. Because what it does is, again, keeping in mind, when I was saying that it not only, the reimbursement rates not just change the rate of a package relative to its pre-reform period, but they change the distances between these closely related packages, like which is sort of the direct upcoding incentive. And so because it changes the upcoding incentive, we can look at how hospitals sort of change the way they code in response and learn something about upcoding. At the same time, it doesn't, and certainly not in the short run, there's no discontinuous change in the cost or the risk of detection. We do some work to show evidence that the costs don't change. So really, there's just a shock to the upcoding incentives. So just some descriptive, this is just a sort of time series.
You want to take some questions, Radhika, or you want to go ahead?
Oh, this is all just after this,
Okay.
I'll flag it, yeah. So this is just some descriptive data. This is what really got us thinking about the coding manipulation story. So this is going back again to the same example of vaginal deliveries. So over time, and this is all claims data. On the y-axis is what we are showing here is the different packages within the vaginal delivery cluster. And on the y-axis is the packages share, like the volume share of each package as a share of all claims for vaginal deliveries. And what you see here, the blue line corresponds to the basic vaginal delivery that I sort of highlighted earlier. That is sort of the bottom coded or cheapest package within this of all the vaginal deliveries. It's 3,500 rupees pre-reform. The red line is vaginal deliveries with episiotomy, and then there's some other services. The main thing I want to show here is that on the 13th of December, literally almost overnight, what you see is a huge change in the composition of how vaginal deliveries are being coded. These basic vaginal deliveries, which were maybe 11% of all vaginal deliveries, jump to about 25%. Episiotomies, which were earlier 50%, dropped to about 40%. And again, if you think about what I was pointing out about the relative rates, the distance between these two packages, before the reform, if you coded a vaginal delivery to an episiotomy, you got 1,500 rupees extra. After the reform, that because the rate for the basic vaginal delivery increased so much, the distance between those dropped to about 500 rupees, basic vaginal. In this case, the incentive to upcode actually decreased substantially. And that, at least, just looking at this, sort of eyeballing this data, it looks like when the incentive to upcode decreased, the upcoding to episiotomy also decreased. But sort of this is, we see, again, I think this is just a couple of examples. This is for ear procedures, just really big changes almost overnight. Right? So this is kind of formalizing this and kind of with the regression with our diff and diff specification, but with essentially the outcome is a package's share of all claims in the cluster. And I'm showing you coefficients of the percent rate change for each package times period. What you see is that things are very flat in the pre-reform period, which sort of supports the basic parallel trends assumption that we need for our diff and diff. What you see is like a 1% change in the reimbursement rate for a package increases that package's share within the cluster by about 3%. Right? So you say, okay, well, so fine, you increase reimbursement rates, volumes for those packages increase, right? There are sort of a few possible explanations for this volume change. One is patient selection. So, that like hospitals realize that they gain more from, so certain packages are now more profitable. They go out and find patients that need those packages, right? So that would be the patient selection story. A second explanation is either changes in over or under provision. So fine, you didn't, let's say if we think about sort of preeclampsia, right? That, the preeclampsia is a better example for patient selection, that maybe you go out and do more work to find patients that have preeclampsia sort of signs and get them to come into your hospital because now you make more money from sort of treating them. Over under provision is a bit more like you didn't find a different kind of person, but you just changed what you did. You started doing things that are more profitable now. And there's lots of discussion of this in the healthcare literature. And a third explanation is that no, you neither changed the kinds of patients that come in with different needs, nor did you change what you actually do. You just changed how you coded the same kinds of patients and the same kinds of services, right? And so I'm going to show you some evidence that, we can't definitively rule out selection or over provision, but we certainly find strong evidence suggesting that manipulation is part of the story. So firstly, we show you that compositional changes are immediate. So this is the same specification that I was showing you earlier, but if you look at the x-axis, rather than months, rather than looking at the 6 months before and after the reform, this is at the weekly level. And what you see is the composition change in packages. A package shares increases within a week of the rate change. And this is sort of consistent with the time series data that I was showing you. This is, sort of formalizing it across all packages and clusters that we have in our study. Second, we show that you don't see similar compositional changes in the public sector, where incentives to upcode are substantially weaker or non-existent. Third, so this is just regression format. What I show is, okay, so the first column is the 3% change in the cluster claim. So this is basically the regression version of what I just showed you, that when a package's rate increases by 1%, its share in the cluster increases by 3%. I mentioned that, sort of the upcoding is not just a function of your own rate increase, but the rate increases of closely related packages, right? The distance between you and other packages. So in column 2, we have your own rate change in the first row. That's a 4% increase. But we also create a measure for the average rate change of other closely related packages. So say for a basic vaginal delivery, it's the average rate change of all the other packages also within the vaginal delivery cluster. And what you see is that when a package's share increases when its own rate increases, but when the rate of closely related other packages increase, my package share decreases. Essentially, there's sort of when other closely related packages increase more, like I reallocate away from myself to them. And so there's this column 2 sort of really shows that within clusters, package sort of volumes are really responsive to the rates of other closely related packages. Column 3 just kind of shows that this is sort of symmetric. You see when for a package, when my rate increases, there's a positive rate change, my share increases. When there's a negative rate change, my share decreases. And sort of relatedly, when the rates of other closely related packages increase, I do less of myself and more of them. When they decrease, I do less of them and more of myself. So this is just sort of reinforcing that we're seeing these changes across the distribution of rate change. But this last column is saying, what we also see is this. So this is an unrelated rate change. So this is a measure of the rate changes of all the other packages in other clusters. So these are not closely related packages. And what you see is my package is, while it's very responsive to the rate changes of other packages within my cluster, it's not at all responsive to to the changes in. So for example, how I code my vaginal deliveries is not at all responsive to what is happening to the rate changes in heart attacks. And this is just sort of proof to show that all of the coding manipulation that we see, all of this response result is really within clusters of closely related packages, which kind of supports the coding manipulation story. The second big piece of evidence we show is using survey evidence. So, we conducted surveys with the patients soon after a claim was filed in their name, and we ask them, what was the some details about the service provided to you. Now, so what we can really only reliably do this for delivery packages. So this is for vaginal deliveries and C-section deliveries, and so I can focus on that. There are two predictions with the survey confirmation. It's a little tricky, but basically, if someone received the most the cheapest package in a cluster, by definition, there's no upcoding in it, right? And so the idea here is that, like, okay, when I see a claim filed for a basic vaginal delivery, I go and ask the patient, what was the kind of delivery you got? Did you get any of these other services? And I create a sort of confirmation rate, like what share of claims for that basic vaginal deliveries were confirmed by the service, by surveys. And what I should say here is that while it's not, we make no claim that a patient is going to be able to perfectly confirm what was done to them, that you shouldn't necessarily interpret the survey confirmation rate as a way of saying that this is the share, this is, as definitive. What we should see is that, however noisy that measure of survey confirmation is, there's no reason to expect survey confirmation by patients to change discontinuously at the time of the reimbursement rate, right? Just because the hospital gets paid more, we just shouldn't necessarily see, it shouldn't affect how the patient responds to us. And so whatever noise there is, that should stay constant overall. And so the intuition is that if a hospital increases its coding manipulation in response to the reimbursement rate, then we should see a decrease in the share of claims that were confirmed by survey, right? So the more, with the reimbursement rate change reform, you see sort of a discontinuous change in the coding manipulation within a certain package, let's say episiotomies or preeclampsia, or whatever it is. If we see a corresponding decrease in the sort of survey confirmation rate at the time of the reform, that kind of increase suggests that there was a discontinuous change in manipulation, right? So that's kind of what the power of the survey that we're leveraging. So coming back to this, but the predictions are slightly different for what we call bottom coded packages. The cheapest package is going to have no upcoding manipulation, right? That is the cheapest package. If there's the hospital has no incentive to manipulate into it. So what you see down below at the bottom is in the pre-reform period, before any of these reimbursements are changed, the survey confirmation of the bottom cheapest package in each cluster is very, very high. In the private sector, it's almost 100%, and it's very similar in public and private, right? And keeping in mind that public sector hospitals have less incentive to manipulate. So that sort of gives us some confidence in our survey confirmation rate. For all other packages where there is sort of scope for manipulation, what you see is, one, that the survey confirmation rates pre-reform are lower, and substantially lower in private hospitals than in public hospitals. So again, this sort of suggests that there is some coding manipulation going on here, and this is a little bit higher in the private hospitals. But what you see is, as a result of the rate change, the bottom coded packages see no change in survey. In other words, that sort of is consistent with theory that the cheapest package in the cluster does not have any coding manipulation. No matter how your volume changes, the survey confirmation rate should not change. But for other packages, what we see is that I show you that when the package's rate changes, the package's share within the cluster increases. Correspondingly, the share of those claims that is confirmed by surveys decreases, which is consistent with sort of that the idea that some of this increased share that we're observing is actually due to coding manipulation. The last column here is just to, again, going back to what I was trying to say is that there's not sort of this manipulation doesn't happen. It happens across closely related packages within a cluster, but it doesn't happen across clusters. So what you see here at the bottom is that at the cluster level, we have really good survey confirmation rates. It's it's sort of strong evidence that hospitals are actually providing what they say at the sort of cluster level. If you say you did a vaginal delivery, you did in fact do a vaginal delivery and not a C-section delivery or not a heart attack related surgery. And this cluster level confirmation rate is not really changed, doesn't really change in response to the rate. Okay. So that's kind of a lot of stuff I threw at you, but just to sort of summarize, I gave you three broad, we see big changes in package level, in sort of package claims or volumes in response to the reimbursement rate. And I said there were three possible sort of explanations. Look, first, sort of patient selection, that did hospitals sort of draw in patients who needed the sort of packages that got big rate increases? One piece of evidence I showed you is that these changes are immediate, within a week. And it's very, very difficult to imagine that a hospital was so effectively able to draw in exactly the kind of patient who needed, pre-eclampsia management within a week of the reimbursement rate change. And secondly, I didn't show you this, but we also find that there's no change. The surveys show no change in the patient risk. So there's no evidence that suddenly preeclampsia patients with risk of preeclampsia or manifestations of preeclampsia were suddenly increasing in our patient pool. So we see no patient risk composition change. No, in the timing and things sort of suggest that really patient selection would be hard to explain this story. For whether the hospitals didn't change the kinds of patients they were seeing, but just changed what they do, we find the main piece of evidence here is the survey confirmation rates. The fact that survey confirmation rates change discontinuously and in precisely the direction we would expect if some of this volume changes for coding manipulation sort of really suggests that this is not just a change in what you actually did, but just a change in how you coded things. There's also, if you look at some of the patterns, it's just implausible that, one of the packages is like whether you did 3 or more antenatal care visits. Now, it's impossible for you to suddenly provide 3 or more antenatal care visits within a week of the reimbursement rate changing, right? Because the antenatal care visits are done over a 9-month period, and sort of you couldn't suddenly retrospectively change that. So, and then finally, there's just the financial incentives to upcode. It's much more profitable to do something cheap and charge more for it than it is to actually just do the slightly higher rated thing. And so broadly speaking, what we see that the evidence for coding manipulation is all of the things I just said, as well as the fact that the changes in sort of coding that we see are responsive not just to shocks to my own profitability, but the relative profitability of closely related packages. It's very sort of consistent with the upcoding incentives. We don't see these compositional changes in the public sector where financial incentives are weaker. And I don't have time to get into this, but we see, what we see is there's, in some areas, upcoding decreases in response to the rate changes, and in other areas upcoding increases. So it's not like these hospitals are just sort of upcoding as much as they can everywhere. What they seem to be doing is making sort of a risk-reward trade-off and really coding strategically where they're going to gain the most relative to the threat of detection. And we find some evidence that this ends up costing the government without changing the composition of service. And finally, just to set up the second part of this paper, because of this, because we see that coding is there's all this coding manipulation, it basically means that a package like a basic vaginal delivery pre-reform, a claim for a basic vaginal delivery pre-reform, and a claim for one post-reform does not actually mean the same thing. There are different kinds of patients included there because of this coding manipulation. And so what, evidence, sort of analysis at the package level, is sort of comparing apples to oranges across time. And so that's, maybe biased. And so instead we collapse things, do things at the cluster level because we find no evidence of coding manipulation across clusters. So that's, maybe this is a good time for questions.
Yeah, so we can open up for questions. I have a few, but I have already asked, so maybe Tarun, Debi, Is Devi around? Yeah, Devi is there. And others. Arun has a question on upcoding and whether the question, the upcoding can be comparable across clusters. You want to respond to that maybe, Radhika, to start off?
Um, yeah, so uh, by comparing upcoding across, maybe if you could clarify when you say upcoding across
So
clusters,
he
you mean?
says that thank you for illustrating. Yeah, Arun, why don't you unmute yourself and ask the question?
Okay, thank you for the opportunity. I mean to know if the result of upcoding was comparable across the clusters. For example, is there a evidence that if a hospital has multiple specialties under offering, then the rate change in one of the cluster is very high compared to the other cluster, and the beds are fixed. So I can at any point of time I can admit only 100 patients, right? So instead of offering the vaginal deliveries more, can I started offering the heart, cardiac patients services more, because rate changes in cardiac services are very high compared to the rate changes in the other cluster like vaginal delivery. So upcoding alongside
Right.
the patient selection, something like that.
Right. So what actually I think, so the way, and I'm going to show you some a result on that actually. Thanks for that question. So what you're talking about is actually, we don't, upcoding is basically sort of faking, sort of claiming that you did something that you didn't do. And your point is about, do hospitals sort of reallocate, given that they have sort of fixed things like beds or supply side sort of constraints, do they reallocate care to the services that are better reimbursed now across clusters? And I will show you that in the next slide actually. So we see that volumes of services that overall got higher reimbursements, whether sort of the cluster of services where reimbursements increased more, see increases in volumes. So that's so that sort of suggests that, and I don't show it today, but we see that the volumes for clusters where the reimbursement increases more, the volume increases, but where the reimbursement decreases, there is a volume decrease. So that does suggest a reallocation. It's not just like they started doing more of the, in your example, heart attacks or something. They also, there seems to be they did less of the things where the rates increased by less, and sort of seem to have moved some of the resources over.
Right. Thank you. This is what I exactly mean, right?
Great,
Okay,
thanks.
Abhishek has a question, just a clarification. Government pays a premium to the insurer and the insurer reimburses the hospital.
Mm-hmm.
If that is the case, do the insurers decide upon the hospital reimbursement rates?
No, actually, it's sort of interesting, and I think this is common across many of these programs. The insurer largely ends up playing the role of a sort of the insurer doesn't design the program. It's largely sort of a third party sort of payments organization, administrator, actually a TPA, basically. So the government designs the reimbursement rates. The government designs how, if you look at the RFPs, everything is sort of set up by the government, and then it sort of puts out this procurement process. All the insurer has to do is sort of administer, review the paperwork submitted by hospitals, and then reimburse the hospitals for whatever, based on their review. And so the insurer has an incentive to try to reduce the coding manipulation by hospitals, because the more it has to pay out, the less it profits. But it doesn't have any say in the reimbursement rates. Those are determined before the RFP.
So I had two observations, Radhika. One is the speed of response of hospitals. It's very intriguing, because that to me is immediate evidence of either chronism or information leakage, or some combination of both existing in the system. Hospitals somehow know this is coming, and once it comes, I'm going to extract rents from the system. They're all prepared in that sense to respond, and some better prepared than others, right? So you may want to nail that mechanism a little bit to understand what's going on by looking into like the social networks of these hospitals with the government and stuff like that. That's one comment I had. And the other one was, so what about the long run welfare effects? I mean, I understand that there's upcoding happening, and people are doing more stenting, etc. But what kind of stents? What's happening to the quality of care? Any thoughts there? Could you ask patients on questions related to that?
Um, yeah. So on the first point, absolutely. Like, okay, so the government itself had not fixed the reimbursement rate changes until about August or September, which is when they gave us this, shared this information with us. But the rates were officially not released until just a few weeks before the reimbursement reform. That said, absolutely, there almost certainly are informal channels through which this information spreads, and hospitals must have, are likely to have prepared to some extent. The other thing is actually, one of the things I was thinking, the hospital is big, how do they sort of manipulate coding? And what you see is that all of the doctors in a ward, so all of the doctors in the labor and delivery area will have the list of BSBY packages with their reimbursement rates with them. They don't have the lists of packages for other, like the delivery people don't have the lists for heart attacks, but the point is simply to say that the doctors make the decision about how something is going to be coded, and they have in front of them the reimbursement rates and lists. So it's really quite easy to say, okay, put this down as a case with preeclampsia. On the welfare effect, so just again just one thing to clarify though is that what I'm showing you is these big changes in composition, but they're not necessarily changes in what was actually done. I think what we're trying to show is that actually a substantial share of this is likely to be just changes in what is being claimed. That said, you're right, that the changing the incentives also changes the incentives of hospitals for what to focus on or what to do, whether to do too much. It's kind of hard, we don't have a good way of looking at the, over provision is just notoriously difficult to pin down, because in most cases there's not even a medical consensus on what exactly a patient required, and so we don't have the power to either even fully identify to what extent things are being over provided. But yeah, so which makes it very difficult to study the welfare effects. But I'll think about that a little bit. Let's see if there's something we can do.
Yeah. Any other questions? Looks like people want to go. It's Independence Day coming tomorrow, but unless there are other questions.
How much time do we have left?
Hello.
We have spilled over by 5 minutes. Somebody has a question.
Oh, wow. Okay.
Vanita? Yeah,
Yeah,
Vanita, please go ahead.
Hello, sir. Thank you, ma'am, for a wonderful presentation. So I'm also doing very much related work. So I'm a PhD student here. So I have few questions. So one is like we were discussing about the role of insurance companies, because they also have like they also look at that how they can maximize their profit, and they'll make sure that they don't do the upcoding things and don't overperform. So there you said that they don't have a say, but if you read their MOU, so they have, like, they can file for the DM panel of the hospital if some insurance, if they find that there is fraudulent practice.
Yeah. Absolutely. So sorry, I was saying that they don't have a say in the setting of the reimbursement rates for different packages, but they're responsible for monitoring the hospitals, and they do actually have a strong incentive to control upcoding, right? It's just that because the more a hospital upcodes, the more the insurance has to pay out, and that reduces their profits. But the point is just, there's sort of limited, it's just difficult to actually verify upcoding. But you're absolutely right that the insurance company does have it is involved in monitoring coding manipulation, and the threat that it has to wield is that it can disempanel hospitals, or it lobbies the government to disempanel hospitals that did a lot of fraud.
Yeah, because in Rajasthan it became a big issue in 2018. Yeah. So they had a big fight. The insurance company was behind about 100 hospitals. They wanted to de-empanel because of these fraudulent practices.
Yeah.
And
yeah, exactly.
Is that during the period of our sample? That could be a cool
no,
event.
Luckily it happened.
So it was
luckily
once
it happened
this
just after.
ABPMJ was rolled out, because they came up with a lot of customer empowerment tools and accountability initiatives. So I think under that, Rajasthan government also had lot of issues. So another thing, like my experience, so I have done very similar work with Maharashtra. So where, like what, as per my discussion with private hospitals, so what they say that they upcode because there is a system of pre-authorization under these schemes. So you have not mentioned about that anywhere. So, and I'm sure in all the once this huge outcry regarding hysterectomy and C-section deliveries unnecessary being done just because of these schemes are there. So they have now mandated pre-authorizations before a hospital can perform a procedure. So what they do is, what the doctors were telling me, what the surgeons, that they have to, because see in a delivery, if we see the percentage of basic with episiotomy, without episiotomy, so I think 90% are going under episiotomy. I don't know if what is the scene in Rajasthan. I'm telling you about Maharashtra, because these days one or other complication is there. And I think the other thing that may have some effect on your results is that when these rates were revised, at the same time the guidelines were also revised, like the private performing C-section or performing other operative procedures while during childbirth, they were like, they mandated that either you need a permission from public hospitals. So I think that was also a strategic move of private providers, that how they can like forego all these rules and then perform, and then still perform it, not just rates. They also had the fear of de-empanelment, and these policy changes must have also affected all this.
Yeah, okay, so there were several points there. On the pre-authorization, absolutely. So that's one of the efforts that the government has, or the insurer, and to help the insurer sort of control over provision, especially, or coding manipulation. But the only thing is that, you know, a lot of these things didn't change suddenly at the time of the sort of policy reform to change reimbursement rates. They really so while I mean, this is sort of consistent with, there is monitoring and oversight by the insurance company, but it's not able to catch all of the sort of coding fraud that's going on, right? On the C-sections and sorry, I lost
episiotomy and the basic delivery.
Right. So I think you're saying that, you know, there's very high rates of very high rates of these of something like an episiotomy. Absolutely, and you see that in our sample, you know, I think about 50% of all vaginal deliveries were coded as those with episiotomies. But again, what you see is that when the coding, the incentive to upcode to episiotomy changes, the sort of the share that is sort of the claims for episiotomy decrease dramatically and sort of overnight. So what we're trying to say is that, you know, there may be some over provision of these things going on, but the nice thing about the rate change is it really allows us to sort of identify, look at how it really provides evidence that some of this at least is just coding fraud, and that changes dramatically with when the incentive to code changes.
Okay, so have you seen in the same graph for C-section how it has gone in relative to basic delivery?
Yeah, so what we find is, so C-section volumes increase because overall C-sections kind of increased. But we don't see, so we kind of treat C-sections and vaginal deliveries as two different clusters, because we don't find that there's coding manipulation between vaginal and C-sections. In part because it would be very difficult.
Yeah,
right,
that's not
right.
possible
So,
even, yeah.
Right. So the C-section, you know, here, if I just kind of show you, you know, we have this like big changes in, this probably doesn't sufficiently explain your thing, but basically we do see that volumes of C-sections increase some, because on average, the reimbursement for C-sections increased slightly, but the government did not increase the overall rate for C-sections too much, precisely because they were worried that they did not want to incentivize hospitals to suddenly start doing too many. So we see a small increase in C-sections, but this graph doesn't explain it, but not dramatic, partly because the incentives did not change that much.
Okay. I think we can wrap up unless there are other questions. Thank you so much, Radhika. Much appreciate your time. So we will socialize this soon. And thank you everyone for sparing your Friday evening and keeping us honest on issues around
Yeah.
universal healthcare coverage in India. Stay safe and take
I
good
just
care. Yeah, go ahead, Radhika.
just before closing, so the coding manipulation results are sort of tricky and take some time to discuss, but we should have a working paper out soon. The sort of big second section of this paper is all about out-of-pocket charges, and specifically sort of trying to disentangle. We find that they're pervasive, but we sort of disentangle why hospitals are charging, and there are some, I think, quite interesting results that I wish I'd been able to get to today, but they should. So keep an eye out on the paper if you're interested in that, or I'm happy to send you results.
Super.
But thank you so much for inviting me today.
Thank you. Thank you, everyone.
Okay, bye.
Bye.